Well, maybe we'll go ahead and get started. We just have a few introductory slides. So, welcome to the first in our series of four CME series for the Yale Center for GI Cancers. My name is Pam Kunz, and I'm an associate professor of medicine and the director of the Center for GI Cancers. And I'm joined by colleagues Dr. Michael Cecchini and Dr. Jill Lacy. And we are thrilled tonight to be presenting to you GI Oncology Year in Review highlights from all of our favorite meetings, AACR, ASCO, ESMO, and ASCO GI. These are my disclosures. And this just gives you a sense of what we're going to be talking about tonight. So this is a broad agenda, so not just neuroendocrine tumors. I'll be speaking about neuroendocrine tumors and hepatobiliary cancers. Dr. Cecchini will be talking about colorectal cancer and circulating tumor DNA. And Dr. Lacy will be talking about pancreas cancer. I'd like to just start with providing some context because I think certainly this is part of what motivates all of us to do what we do. But in terms of cancer statistics for 2024 and estimated new cases, GI cancers comprise about 11% of cancers in males and 10% of cancers in females. This is for new cases. However, in terms of the estimated deaths, we see a disproportionate number compared to the new cases. So about 27% of estimated deaths in men are from GI cancers and 20% in females for GI cancers. So I think this really motivates a lot of what we do in terms of drug development and clinical trials as we really need better therapies. And I'd like to, this is exciting to think about what drugs have been approved over the last year. So these are GI cancer FDA approvals since January of 2023. So we've had approvals of tucatinib, trifluridine tipiracil, Pembro in biliary tract cancer, fruquintinib in colorectal, Pembro in HER2-negative gastric or G-junction adeno, and then liposomal irinotecan as part of NALIRIFOX in advanced pancreas cancer. So I'm going to be responsible for talking about neuroendocrine, and I'll also talk about a couple of HCC trials. I'm going to focus on 5 abstracts, and it will be a little bit of a rapid review. So the 3 of us are each going to talk in about 20 minutes, and then we're going to leave time for Q&A in the end, and we're also going to go over a few of our clinical trials. So the first trial I'd like to review is the Alliance study, which is A021602. It's a phase 3 double-blind study of cabozantinib versus placebo for advanced NETs. And this is the CABINET study led by Dr. Jennifer Chan. So it was essentially 2 separate studies done together. So there was an extra pancreatic NET cohort and a pancreatic NET cohort. Both were randomized 2-to-1 cabozantinib versus placebo. And open label cabozantinib was allowed for patients who were on placebo at time of progression. The primary endpoint was progression-free survival. So this study met its primary endpoint. We can look at the PFS for both of the cohorts. So this is the extra pancreatic NET cohort. As you can see in the yellow box, median progression-free survival was longer in the cabozantinib arm at 8.3 months versus placebo of 3.2 months. This has a hazard ratio of 0.45. The pancreatic NET cohort similarly met its primary endpoint. The median PFS was 11.4 months in cabo and 3 months in placebo with a hazard ratio of 0.27. I think I should also mention that just for our audience, progression-free survival is actually the preferred primary endpoint for neuroendocrine tumor studies, mostly because it's an indolent disease and OS would be an impractical endpoint, and often patients go on to get many subsequent therapies. Overall response and response rate is actually quite important in thinking about new agents, as the large majority of our existing approvals generally yield stability and don't generally yield response. So you can see in the extra pancreatic NET cohort, the response rate was low at 4%, and for the PNET cohort, it was actually higher at 18%. So the take-home points from the CABINET study: is this clinically relevant? Yes. It improves PFS for both EP and PNET. And I think a really important takeaway is that the response rate is clinically meaningful in pancreatic NET, no difference in OS. Is it practice changing? Likely. Cabozantinib should be considered, in my opinion, as a treatment option for advanced NET. The FDA review, however, is pending likely this year. Okay, abstract 2 for NETs. This was a big year for randomized studies in NETs. So this is the NETTER-2 study. It's ludotatate in newly diagnosed patients with advanced grade 2 and grade 3 well-diff GEP-NET. And this was a first-line study. So this study enrolled patients with advanced somatostatin receptor avid, well-diff, grade 2 or 3, and this is a key takeaway. So a higher Ki-67 than the current indication. This is grade 2 and 3, but 10 to 55% Ki-67. Patients were randomized 2-to-1 to receive ludotatate, 4 total doses versus high-dose octreotide. And crossover was allowed for patients who were on the high-dose octreotide arm, and retreatment is also allowed for patients that progressed. This is beyond a year of progression of having received their initial 4 cycles. So progression-free survival was the primary endpoint. NETTER-2 did meet its primary endpoint. As you can see in the yellow font, the median progression-free survival was 22.8 months versus 8.5 months with a hazard ratio of 0.27. So a really significant 72% reduction in the risk of disease progression or death with the experimental arm. Also for this, I'd like to highlight the significant response rate. So objective response was higher for ludotatate than in the octreotide arm. You can see that we have approximately, if we look at the response rate here, 43% in yellow for the ludotatate arm and 9% for the octreotide arm. So take-home points. Yes, it's clinically relevant. First-line ludotatate plus octreotide significantly extends PFS by 14 months in patients with grade 2 or 3 advanced GEP-NET. And is it practice changing? Also likely. So ludotatate should be considered as a first-line option in this population. However, I think that it's not the right first-line option for all patients. Somatostatin analogs are likely still going to be commonly used in the first-line setting, but it's really nice to know that this is something that can yield tumor shrinkage for patients that have bulky disease or symptoms from their disease. And FDA review is pending also this year. Okay, we'll move into HCC for the last few abstracts. So IMbrave 050 was atezo plus bev as adjuvant therapy for HCC with a high risk of recurrence. So this was a study of patients randomized 1-to-1 to atezo bev versus active surveillance. Crossover was allowed. They defined high-risk HCC as tumors greater than 5 centimeters, greater than 3 tumors, macrovascular invasion, microvascular invasion, and poorly differentiated histology. And the primary endpoint was recurrence-free survival. And this is the primary endpoint of recurrence-free survival by central review. In this figure, you can see that the median recurrence-free survival was not met in either arm. However, the 12 months recurrence-free survival was statistically different at 78% in the atezo-bev arm versus 65% in the active surveillance arm for a hazard ratio of 0.72 and a statistically significant p-value. So is this clinically relevant? Yes. Adjuvant atezo-bev improves recurrence-free survival in patients with HCC at high risk of recurrence. And importantly, this represents the first positive adjuvant study in HCC. And is it practice changing? Also, yes. Atezo-bev should be considered for these patients at high risk of recurrence. However, I think an interesting point is that moving this regimen earlier will inevitably impact the treatment and sequencing of treatments for advanced disease, and FDA review is also pending. The next study, this is in biliary tract cancers, is the Phoenix CCA2 study. futibatinib for advanced intrahepatic cholangiocarcinoma that is unresectable or metastatic, that have FGFR2 fusions or other rearrangements. So this was a single-arm study of futibatinib at 20 milligrams for all patients, and patients were treated until disease progression, and the primary endpoint was objective response. And this is by independent central review. So in this study, I'd like to just highlight that the top bar looking at FGFR2 alterations, patients with both fusions and rearrangements were eligible for this study. You can see that fusions were more common. And then we see the waterfall plot here, and highlighted in the yellow box is the response rate, which is 42%. So you can see that all of the complete responses are in blue and the partial responses are in green. Total number of patients was 103, and this was a large international effort. This is the progression-free survival curve showing a median progression-free survival of 9 months. So take-home points, is it clinically relevant? Yes. So 10 to 15% of intrahepatic cholangio harbors an FGFR fusion or rearrangement. And this study did in fact meet its primary endpoint. They used historical control to determine their statistics. And so this response rate that they found in the study of 42% was much higher than compared to the historical control response rate of 10%. Is it practice changing? Yes. And futibatinib was already granted accelerated FDA approval in September of 22 for patients with advanced intrahepatic cholangio with an FGFR2 gene fusion or rearrangement. All right, and this is the last HCC study. So Emerald-1 was presented at ASCO GI this year. It's a phase 3 randomized study examining TACE with durva, with or without bevacizumab, in patients with unresectable HCC. So as you can see, this is a 3-arm study. The orange line shows arm A. So patients receive durva TACE followed by durva plus placebo. The second line, which is green, is durva plus TACE followed by durva bev. So that's the kind of all 3 combined. And then the gray boxes indicate arm C, which is placebo plus TACE followed by placebo. The primary endpoint is progression-free survival for arms B versus C. And then there were secondary endpoints that looked at other comparisons. And so the key takeaway is that the study did in fact meet its primary endpoint. So progression-free survival with durva plus bev and TACE versus placebos plus TACE met its primary endpoint. The progression-free survival was improved by 6.8 months compared to the control arm. So the hazard ratio was 0.77 and the p-value was 0.032. You can see, I want to just highlight that the arms kind of do come back together towards the end. The secondary endpoint of comparing the other 2 arms, so this is durva plus TACE versus placebo plus TACE, did not show a difference in progression-free survival. And then lastly, looking at response rate, also important for some of our patients who have symptoms and need an objective response. So objective response was improved with both of the durva TACE and then durva bev TACE containing arms. So take-home points. So is this clinically relevant? I think yes. It met its primary endpoint, demonstrated a PFS benefit of the all 3 together, the durva bev TACE versus placebo TACE. However, no difference in that other comparison that I mentioned with the durva TACE versus placebo TACE. Is this practice changing? I probably should say debatable. I think that this certainly represents an option for patients with HCC. However, I'd like to highlight that it's really unclear what TACE adds to systemic treatment alone, as there was no arm with only durva-bev. We may be able to extrapolate with some of the atezo-bev data. I think also certainly in diseases outside of neuroendocrine tumors, there's some debate, is PFS an accurate surrogate marker of survival? So there's still some questions that remain. Okay, so I'm going to just highlight this before I pass the baton. But we have a really exciting four-series CME this year. So this we're kicking this off. Please come back in March for liver cancer, moderated and hosted by Dr. Stein. Supporting our patients, really talking about supportive care, financial toxicity, hosted by Dr. Jeremy Kortmansky. And then gastroesophageal cancer will be hosted by Dr. Jill Lacy. So I'm going to stop share and pass to my colleague, Dr. Cecchini.
Great, thank you. Screen here, great. Thank you so much, Dr. Kunz. My name is Michael Cecchini. I'm an assistant professor of medicine and medical oncology. I'm co-director of the colorectal cancer program within the Yale Center for GI Cancers. And I'm going to talk about colorectal cancer as part of our CME this evening. Here are my disclosures. And here's my outline for the evening. So first, I'm going to talk about the Checkmate HW study of Ipi/Nivo, and then I'm going to talk about sotorasib and panitumumab. Then I'll talk about trastuzumab deruxtecan updates, then fruquintinib, followed by some presentations in the localized setting of Prospect, Prodige for rectal cancer, and Bespoke and Galaxy for ctDNA. So first, an update in MSI-high colorectal cancer, and the question being, is there a role for combination immune checkpoint inhibitors? I think it's first important to establish where we've been / kind of where we are at the time of this presentation. And that's with first-line pembrolizumab for MSI-high, microsatellite instability high colorectal cancer, the Keynote 177 study, which established pembrolizumab as standard of care initial therapy based on this PFS curve. And you can see very clear separation of first-line pembrolizumab showing superiority over chemotherapy in all subgroups. So the Checkmate HW study was a three-armed study as initial therapy for microsatellite instability high cancer, colorectal cancer, looking at Nivo alone, Nivo plus Ipi, Lumumab, or chemotherapy as first-line therapy. The data that's been presented thus far at GI ASCO last month was Nivo Ipi versus chemotherapy and PFS data. And we saw a very impressive hazard ratio, very impressive separation of these curves here. You can see the Ipi/Nivo arm in the brownish orange color and the chemotherapy in the gray. At 24 months, you have 72% of patients in the Ipi/Nivo arm with deficient mismatch repair or MSI-high colorectal cancer. They're progression-free and alive compared to 14% with chemo, hazard ratio 0.21, so very impressive over chemo. Of course, we want to see how the nivolumab alone arm looks, but we'll have to wait a bit longer for that data. So my take-home points, is this clinically relevant? Absolutely. Those are very impressive separation of curves, very impressive hazard ratio. There were no new safety signals. Overall, there's actually less toxicity than with chemotherapy. Is this practice changing? I say yes. Ipi/Nivo is a new standard of care, but without any data with single-agent nivolumab, it is not the standard of care. So I think pembrolizumab alone is also still a standard of care based on Checkmate 177. But Ipi/Nivo versus Nivo will tell us more as that data comes available. Now I'm going to pivot to the treatment refractory metastatic colorectal cancer setting for microsatellite stable colorectal cancer. And I'm going to focus on three treatments. Sotorasib panitumumab is where we'll start. So sotorasib and panitumumab was shown to improve PFS for KRAS G12C mutated colorectal cancer tumors. So this was a study that in arm 1, they had a high dose, a 960 milligram dose of sotorasib, a lower dose sotorasib in arm 2 versus standard of care with PAS 102 versus regorafenib in the standard of care arm. And what was the data that was shown? This was presented at ESMO, but then has been published. So I'm showing the figure from the New England Journal publication here, where we see a progression-free survival benefit with the two sotorasib panitumumab arms compared to the blue standard of care. You can see in the 960 milligram dose that median PFS was 5.62. Both had hazard ratios that were quite impressive, 0.49 for the 960 dose compared to standard of care chemotherapy. Last month at the GI ASCO, the investigators also presented some quality of life data from that study. You can see in the left-hand side of the screen is the 960 milligram sotorasib group. And you can see to the left here, virtually all quality of life measures, with the exception of diarrhea, and I think that's important to point out, were favoring sotorasib and panitumumab over the TAS-102 or regorafenib. A better quality of life and progression-free survival benefit. So is this clinically relevant? I think with showing improved PFS and improved quality of life, yes, those are both relevant endpoints that seems that were superior with sotorasib and panitumumab. Is it practice changing? Mostly yes. It is definitely something I will use in my third line setting for KRAS G12C mutated tumors. But I do think the overall survival results are needed for a full yes, and those are awaited and should be available soon, we hope. What about updates in HER2-directed treatments? So KRAS G12C in the single-digit percentage points in terms of its incidence, and same with the HER2, about 4% of metastatic colorectal cancer. So where we are right now, this is the FDA-approved regimen. Dr. Kunz showed on her first slide that this was actually approved last January, tucatinib and trastuzumab. So that's been the standard of care for HER2-positive disease, and it's approved by the FDA. You can see a nice waterfall plot here for tucatinib, the small molecule, and trastuzumab. You can see 2 years overall, 2-year overall survival at about 51%. This is non-randomized data. I think that's important to point out, but in this rare biomarker, this led to an FDA approval. So CRCO2 is a study with the trastuzumab deruxtecan that had a slightly different eligibility criteria from the last study. So they allowed the enrollment of patients with KRAS mutated disease, which were excluded from the prior study with tucatinib, and they also allowed prior treatment with other HER2-directed therapies. It was ultimately a 2-arm study, but really the dose of 5.4 milligrams per kilogram is the main dose that has moved forward in this disease, and so that's what we'll focus on for our analysis. Important to realize that most of the patients enrolled in the study actually had IHC 3+, but 2+ FISH positive was allowed for enrollment, but 80% were IHC 3+. This is the waterfall plot. Now, getting back to that biomarker, if we look at the response below the x-axis here, you can see in the dark blue, these are the IHC 3+ tumors versus the 2+ FISH positive in light blue. And as you can see, some of the more of those patients lie on the left side of this graph. The majority of patients with cytoreduction have IHC 3+ tumors. When we look at survival, we see in this essentially the fourth line setting for many of these patients, median PFS of 5.8 months and 13.4 months for overall survival. These are encouraging numbers. When we again look at some of these subgroups here, we really see that the IHC 3 positive group, 46.9% of these patients had a response rate, 30 out of 64. When we look at the IHC 2+, in FISH positive, we're seeing only 1 out of 18 patients respond. So the majority of the benefit is seen in the IHC 3+ group. We're looking at the RAS mutated tumors, we see 4 out of 14, 28.6% of these patients respond. That's a meaningful subgroup for me because when we have the scenario that somebody is RAS mutated, this is the first time we're seeing any real benefit with RAS mutation and HER2 positivity with a HER2-directed therapy. And then again, prior HER2 treatment, we are also seeing those patients still benefit from trastuzumab deruxtecan after some other HER2-directed therapy. So those two subgroups were very meaningful to me. So clinically relevant, yes, because those two subgroups, again, are clinically meaningful, seen after prior HER2-directed therapy and efficacy in KRAS mutated tumors. I think it's practice changing for those groups of patients, and trastuzumab deruxtecan is the only HER2-directed therapy that really demonstrates benefits in those settings. And it really validates an option, it as an option after prior HER2-directed therapies. So just one quick slide on the FRESCO-2 data, which now has been published. So I'm including the Lancet publication there, but it's important that we're aware of this new FDA-approved regimen that was approved within the last year. So this was a study of fruquintinib, a small molecule that primarily targets VEGF 1 through 3. And basically in all subgroups, we saw an improvement in median PFS of 3.7 months compared to 1.8 months with the placebo. And this was again fourth line setting, and then fruquintinib 7.4 month overall survival versus 4.8 in the placebo group. These patients had either received TAS-102 or regorafenib prior to enrollment in this study, and both of those subgroups saw benefit. So even regorafenib prior to fruquintinib, the sequential use of these molecules, which have very similar anti-tumor properties, still showed benefit for fruquintinib. So this is now an FDA-approved regimen. Take-home points to this. I think that is a meaningful PFS and OS in the fourth line setting. It seems to be a reasonably well-tolerated treatment as well. Survival benefit was seen in all subgroups. And I do think this is, again, practice changing, and now it's approved by the FDA. So what are my conclusions for these biomarker-driven therapies? So KRAS G12C is a third-line regimen, and that's been shown to have this PFS benefit listed here with a hazard ratio of 0.49. Tucatinib and trastuzumab deruxtecan have been studied in single-arm studies. So I do think that's something to note when we look at these numbers. But nevertheless, these numbers for a treatment refractory patient population stand out with a median overall survival of 24.1 with tucatinib trastuzumab, and then over a year with trastuzumab deruxtecan. While we see lower numbers for fruquintinib and the bottom row here, this is a different patient population in the fourth line setting, and I do think these are meaningful benefits. So I have a couple of updates in rectal cancer, and this is where there are some major updates at ASCO in June of 2023. And this was the PROSPECT study and the PRODIGE 23 study. So in the PROSPECT study, this sought to look at a question of de-escalation of therapy. Could we omit chemoradiotherapy for certain patients? And so it's very important, especially when de-escalation, we're clear on the enrollment population. So these were patients that had T2N positive, so N1 only, by the way, T3 node negative or T3N1 positive, patients that were not going to require an APR. So mainly mid to high rectal cancer. But again, it was really just whether or not an APR was needed. And this looked at non-inferiority, and PRODIGE 23 looked at a more advanced, typically patient population, and sought to look at overall survival, whether or not FOLFIRINOX as part of TNT or as part of neoadjuvant therapy was beneficial to the traditional chemoradiotherapy, surgery, and adjuvant chemotherapy approach. So the PROSPECT study, which was presented at a plenary session last June, when it kicked off in 2011, pelvic chemoradiation with either 5-FU or cytarabine was the standard of care as an initial approach. But we've known it reduces local pelvic recurrence, which is a highly morbid outcome, and neoadjuvant pelvic chemoradiation was the standard of care for a couple of decades. But there's an effort to see if there's the possibility to reduce some of the long-term toxicities from radiation. So in this study, patients were either randomized to that control arm or to FOLFOX for 6 cycles. And if there was at least a 20% reduction in the size of the tumor, then chemoradiotherapy was omitted and patients went directly to surgery and then potentially received adjuvant chemotherapy. This is a non-inferiority study, so that was a primary endpoint. But again, looking at the eligibility criteria for this is really important so that we apply these findings to the correct patients going forward in our practice. So T2N1, T3N0, T3N1, these were the tumor stages that were potentially enrolled into the study. Chemoradiation had to be indicated in the first place, and patients could not need an APR. They had to be candidates for sphincter sparing surgery. The lymph node status here is also a bit an issue that I think we can easily get hung up on. So patients could not have essentially N2 disease, 4 or more pelvic nodes, but defined as 1 centimeter in the short axis. So there's a lot of nuance here. What do we do in the scenarios when there's 8 millimeter nodes and there's 5 of them, or more than 5 millimeter nodes or something that have suspicious features? I would argue if we think that the patient really has N2 disease, even if it doesn't meet the strict criteria, we should be careful about applying this de-escalation strategy. T4 tumors and other high-risk features were also not allowed in enrollment. So what do we see? There's non-inferiority margin was of 1.29 was not crossed, and you can see very clear overlap in these curves here, and non-inferiority was met. So clinician reported toxicity revealed more chemotherapy toxicities when you're getting chemotherapy. I think that seems kind of obvious, and more and less in the adjuvant setting and in the after surgery setting for the patients that had already received the bulk of their chemotherapy up front. But interestingly, we saw less neuropathy in this selective chemoradiation arm at 12 months, and presumably we'll see less long-term toxicity from radiation if you're not getting radiation anymore. But non-inferiority was met. Overall survival, you can see these curves completely overlapping. In local recurrence, again, these curves completely overlapping. So selective chemoradiation did not seem to have an impact on these important survival endpoints. So is this clinically relevant? Absolutely. Radiation can be safely omitted from these select stage tumors in this select circumstances without high risk features. I don't think we should be deviating outside of the eligibility criteria from this study. Inadequate nodal staging is critical, and we should ideally be doing this by MRI and having these patients see surgery, radiation, regardless, to discuss the pros and cons and decide which whether or not the patient should be a candidate for selective chemoradiation. I think this is practice changing. No impact on survival was seen omitting radiation. So how about the other big rectal study? This was a PRODIGE 23 study, a study out of France that had the same, essentially the same control arm, but had more, potentially more advanced tumors. So up to T4 tumors were involved, up to N2 tumors were enrolled, and patients were randomized to either upfront chemoradiation, surgery, and adjuvant chemotherapy, or neoadjuvant FOLFIRINOX given for 6 cycles, followed by chemoradiation, followed by surgery, followed by adjuvant chemotherapy. So these were the long-term follow-ups from the study. We had seen benefit, we had seen disease-free survival benefit with this regimen before. We're on the left-hand side here seeing longer follow-up of that endpoint, and we see it's maintained at 5 years. It was about 8%, and again, 5% at 7 years. But what about overall survival? We've never seen an overall survival benefit really in any of our total neoadjuvant studies. But we finally did. We finally did with this triplet regimen. We see a 5-year overall survival benefit of close to 7% and then about 5% at 7 years. So for the first time, we were seeing a statistically significant overall survival benefit by moving the chemotherapy up. A different chemotherapy, though, moving triplet chemotherapy up. So this is clinically relevant for me. This is the first total neoadjuvant chemotherapy for rectal cancer to clearly demonstrate improvement in overall survival. It's practice validating rather than maybe practice changing. TNT has already been incorporated into practice. PRODIGE 23 demonstrates FOLFIRINOX to be a standard of care for fit patients. So for my fit patients that I think can tolerate triplet chemotherapy, especially now that there's a clear overall survival benefit, it would be my go-to. So what about circulating tumor DNA? We're going to finish with a couple of abstracts that were presented last month, Galaxy and Bespoke, which were both observational studies. So again, where are we right now for ctDNA in stage 2 disease? So Bespoke and Galaxy included stage 2 and stage 3. But this was a study now presented at 2 ASCOs ago and now presented in New England, published in the New England Journal that showed that if we have stage 2 colorectal cancer and we use ctDNA positivity versus negativity to make a decision about whether or not to give it adjuvant chemotherapy, we see pretty similar endpoints compared to looking at the typical pathologic factors for high-risk disease. So there was no difference in recurrence-free survival rates that were seen with selecting the receipt of adjuvant therapy purely based on the ctDNA results. But when we get into the weeds, we do see that there are patients that with the selective use of adjuvant chemotherapy based on ctDNA status maybe have a little bit higher rate of recurrence. And so if we look at one of the supplementary figures from that study, we see PT4 tumors that are stage 2 that were negative ctDNA essentially have a higher risk of relapse than the positive ctDNA group, which actually got then adjuvant chemotherapy as well. So I think we have to be careful about all of the risk factors and negating those based on the ctDNA status. So for my T4 disease scenarios, I'm not going to use this necessarily as a de-escalation strategy. But on the other hand, on the T3 and 0 negative patients, we can be very reassured that those results are going to be associated with a very low risk of recurrence, which is still not 0, though. So the Galaxy study was an observational study. Stage 2, it was actually stage 2 through 4, but mainly stages 2 and 3, where patients underwent surgery, and there's this MRD window that ctDNA was drawn, 2 to 10 weeks post-surgery. So essentially 3,000 patient study. And we again see the incredible prognostic association of ctDNA positivity versus negativity, versus positivity. But what's very interesting is when we look at the events, we see that about 58.8% of patients that relapse were positive, meaning the sensitivity of this test is clearly not 100%. So Well, we're trying to decide what to do at this 8 to 12 week window. It's important to note that sensitivity across other studies as well only holds up to about 40 to 60% of the time. So because more patients are also going to be ctDNA negative, you're actually going to have more relapses ultimately in many of these studies in the ctDNA negative group when you talk about absolute numbers. So it's probably not really a sensitive test enough to really be de-escalating therapy in scenarios that is otherwise indicated. But again, prognostic value is pretty undisputed. So ctDNA clearance at 6 months, this is an interesting curve they showed. So for patients that got adjuvant therapy and they cleared, they went from positive to negative. Those patients seem to have somewhat of a tail to the curve, although the follow-up is certainly not long enough. And again, this is all observational data, suggesting, but definitely not demonstrating some predictive benefit potentially. And the bespoke study, which was the Galaxy study that I just should have done in Japan, the bespoke study was done here in the United States primarily, and showed very, very similar data and very similar scenarios. So again, post-operative ctDNA was evaluated. We saw a very clear disease-free survival benefit and around 55% sensitivity, so very similar sensitivity numbers. And again, a very prognostic curve. Now, when we look at the patients in the essentially the adjuvant setting, so in blue here, all these patients were positive. In blue, these patients got adjuvant chemotherapy, and you do see there is some tail to this curve, but this is in weeks. We certainly need more follow-up to really know what's going on here in the long term for these patients. But I think kind of the gist we see here is there's a suggestion that there's a benefit in the MRD positive patients getting adjuvant therapy, where there's less of a suggestion of benefit in the MRD negative patients. But ultimately, this is observational, not enough follow-up time. We need some of these randomized studies that are ongoing to really make a determination about whether or not these are really predictive markers for benefit of adjuvant chemotherapy. They are very clearly prognostic, though. I also thought one additional piece of information that was presented at GI ASCO that was very interesting was the quality of life data that showed that in general, this is very well accepted by patients. And that's always been a concern about this assay. When you maybe are giving a positive result to somebody, and there's uncertainty what to do with that result. So take-home points, I think this is clinically relevant data. ctDNA is already being used widely, and we need to be able to counsel patients on its limitations, especially its sensitivity and the potential for false negatives. It's one of our most prognostic biomarkers available. Again, that's well established. And now we can, I think, surmise that it seems well accepted by patients. I don't think this is practice changing. Prospective clinical trials are awaited to confirm the predictive power for ACT benefit. And I think we cannot be really using these assays to omit therapy in scenarios that we would otherwise use it. Again, I would argue stage 4 disease, T4 disease, and then again in essentially all stage 3 disease. Thank you so much. I'm going to pass the baton to Dr. Jill Lacy now.
So thank you, Michael. I'm going to share my screen. Okay, well, good evening, and thank you all for joining us tonight and staying here through the dinner hour. I'm going to be focusing on some of the updates in pancreatic cancer over the past year. There has been a lot of activity in the gastroesophageal cancer space, very exciting. So we're going to devote a whole session to that in May. So stay tuned and come back to join us for that. Here are my disclosures. So the agenda for my talk is here. I'm going to talk first about 2 studies in metastatic disease, then pivot to localized disease. So I'm going to start out with the first update, which is a statistic. In January, just last month, the American Cancer Society put out their statistics about pancreatic cancer survival, and the 5-year survival has inched up to 13%. And although that is still a disappointingly low number, I think it's important to appreciate that there has been more than a 50% increase in 5-year survival over about the last decade. I think this is particularly striking because we have not had any breakthrough drugs approved. We have had no major developments that have carried us forward, such as immune checkpoint inhibitor therapy. So what this is telling us is that if we continue to work hard with the tools that we have in our toolbox to optimize treatment, earlier diagnosis, better surgical techniques, better radiotherapy techniques, more effective systemic therapies, and importantly, advances in supportive care, that we can improve the outcomes for our patients, including survival. So we're going to turn now to metastatic disease, a very highly lethal cancer with median survival less than a year in most studies and less than that in real world. And we heard two studies that, again, were focused on optimizing the tools that we have in our toolbox, looking at which is the optimum treatment to start with of the two standards that we have, the triplet FOLFIRINOX against the doublet gemcitabine and nab-paclitaxel. So we'll start with NAPOLI-3. This was a randomized phase 3 study that compared the triplet fluorouracil oxaliplatin with nanoliposomal irinotecan rather than irinotecan and FOLFIRINOX compared to nab-paclitaxel and gemcitabine. These were treatment-naive patients with metastatic disease, a good performance, ECOG performance status of 0 or 1. There was no age cutoff. Patients had to have measurable disease. This was a large study, and I would applaud the investigators and patients. This study began in February of 2020 at the onset of the COVID pandemic and was completed in a couple of years. The doses of the regimens are shown here. Notably, the dose of oxaliplatin is less than what we use in FOLFIRINOX, 60 milligrams per meter squared, and a lower dose of irinotecan when it's encapsulated in liposomes. So this was a positive study. The primary endpoint was overall survival, and they met their primary endpoint. Both overall survival as well as progression-free survival were better by about 2 months with NALIRIFOX, and the 12 and 18-month survivals were better as well. And the numbers are shown here. The median overall survival was 11.1 months, and if you recall, in 2011, the median overall survival of FOLFIRINOX in the PROTEGE trial comparing FOLFIRINOX to gemcitabine was exactly 11.1 months. There really was no difference in overall safety in terms of grade 3-4 events, serious adverse events, or deaths. There was some difference or trade-offs in toxicity. So in the gem-nab arm, there was more hematologic toxicity, which I think we all see in the clinic. In the NALIRIFOX FOLFIRINOX arm, there was more GI toxicity, as we would expect, diarrhea and nausea. Neuropathy was similar, a low incidence in the NALIRIFOX arm relative to what we're used to seeing, and probably because the oxaliplatin dose was lower. They did not include a quality of life analysis, and I think that would have been extremely helpful for us trying to make decisions about which regimen to choose for our patients. So the authors' conclusions are shown here, and they rightfully concluded that NALIRIFOX is statistically better than gemcitabine and nab-paclitaxel in terms of overall survival and progression-free survival. That is what this study showed, and they conclude that the results support NALIRIFOX as a new reference regimen and possibly a new standard of care for the first-line treatment of patients with metastatic pancreas cancer. And based on NAPOLI-3, last week the FDA did approve irinotecan liposome for this indication. But I would say maybe not so fast, because just a few months after the presentation at ASCO and the publication, we heard about another study looking at the same question, triplet therapy with FOLFIRINOX versus doublet therapy with gemcitabine and nab-paclitaxel. This study was conducted in Japan, JCOG 1611 or GENERATE. And here's the schema, very similar to NAPOLI-3. They had a third arm, which I'm not going to focus on, with S1, which is not available in the United States. So again, a large study. They used modified FOLFIRINOX, which we're all familiar with now, dropping the bolus, reducing the irinotecan, and standard doses of nab-paclitaxel with the primary endpoint of overall survival. And here are the Kaplan-Meier survival curves. And I think this study was a bit of a surprise to us, having just heard about NAPOLI-3. So FOLFIRINOX appeared to be inferior to gemcitabine and nab-paclitaxel. What's notable is the very impressive overall survival with the doublet, 17 months. We've never seen a 17-month overall survival in any randomized trial in metastatic pancreas cancer. So I think we're all somewhat perplexed about that. It's encouraging. I don't think we quite know how to interpret that. So the authors have concluded, and I think rightfully so based on their data, that compared to FOLFIRINOX, Gem Abraxane is recommended as the first-line treatment for patients with metastatic or recurrent pancreatic cancer. I would add this study was terminated early for futility because they felt that they would be unable to demonstrate the superiority of the triplet. So now we have two studies, finally, after a decade, comparing the two standard regimens that we've been using in the clinic, NAPOLI-3 and JCOG 1611, with dueling conclusions. This is just something to think about as we go forward, and I'll talk about how I interpret this. One of the big questions, of course, is should we now pivot from modified FOLFIRINOX, which we're all very comfortable using, to NALIRIFOX? It would be terrific if a randomized prospective trial was done comparing these two with a quality of life analysis, but I doubt that will ever be done, and so we are left with cross-trial comparisons, which of course is always flawed. And I've summarized the cross-trial comparisons here, and I think we can conclude that there's not a huge difference in overall survival, a suggestion that maybe the modified FOLFIRINOX is a bit better. Similar story with PFS and response rate. And then in terms of toxicities, again, a similar story. No clear winner here. A lot of neutropenia with FOLFIRINOX that can be mitigated by using growth factor. Diarrhea is going to be a consistent side effect that we're going to see with this regimen, and of course neuropathy. And neuropathy was less with NALIRIFOX with the lower dose of oxaliplatin, so that's worth noting. So to conclude, I think we can say from NAPOLI-3 that NALIRIFOX is better than Gem nab-paclitaxel in a global population in terms of survival. The toxicities differ, but the overall safety appears equivalent. When you look at NALIRIFOX and FOLFIRINOX in cross-trial comparisons, recognizing the deficiencies in doing that, they are similar in efficacy and safety. I do think that NAPOLI-3 does provide convincing support for the continued use of first-line triplet chemotherapy in metastatic PDAC in a global population, but it was not superior to the doublet in the Japanese population in the GENERATE study. So I think in terms of conclusions, I think we can use clinical equipoise in making decisions about what regimen to start within our patients. NALIRIFOX and modified FOLFIRINOX are both reasonable and possibly the best initial therapies in the United States. But nab-paclitaxel and gemcitabine remains a very appropriate alternative initial therapy. And that remains the preferred backbone for the addition of investigational agents in clinical trials, and I think that is certainly still appropriate. As I mentioned, we'd love to see a comparison of FOLFIRINOX versus NALIRIFOX. I don't think we will. And so this is the data that we have to work with. And what we really need are accurate predictive biomarkers to help us choose which regimen is best in each individual patient. That work is ongoing and a story to be continued. So the take-home points from these two studies, are they clinically relevant? Absolutely, yes. I think we can comfortably apply that clinical equipoise in choosing amongst these three regimens. Our decisions will be based, as always, on medical comorbidities, age, BRCA status, and so on. Practice changing, I would say not really. We're comfortable with these regimens. I think that will continue. And I think I personally still feel very comfortable enrolling patients on clinical trials using gemcitabine and nab-paclitaxel as the chemotherapy backbone with the addition of novel agents. So I'm going to turn now to some of the emerging data with targeted therapies in pancreas cancer. And I think these studies are really giving us great hope, I would say renewed hope, that we're now finally entering the era of precision medicine in pancreatic cancer. So I'm going to start with what's been happening with KRAS inhibition in PDAC. And I think you've all seen this pie chart showing the mutations that we identify in pancreatic cancer. And as you know, 90% of patients with PDAC harbor mutations in KRAS. Most of these are point mutations. with a single amino acid substitution leading to constitutive activation of KRAS. These mutations, in most cases, are in codon 12, which encodes a glycine, G12, with substitutions leading to G12C, cysteine, G12V, valine, G12D, aspartic acid. There are point mutations in codon 13 and 61 as well, much less common. I think it's really important to highlight that about 10% of our patients are KRAS wild type. And this is where we're going to find those potentially highly druggable alterations, many fusions in this subgroup. I will mention some interesting data targeting the NRG1 fusion that's we see in the KRAS wild type group. So turning now to KRAS G12C inhibitors in PDAC, which does represent less than 3% of patients with PDAC. This was a very busy year for G12C inhibitors in pancreas cancer. There were 5 either presentations or publications with G12C inhibitors in pancreas cancer, which is, I think, quite stunning. I'm going to highlight one that was presented at ASCO GI. All of these inhibitors have the same mechanism of action. They all covalently bind to the cysteine residue in codon 12, and they irreversibly bind the GDP-bound KRAS into its inactive state, locking it there. So at ASCO GI, we heard about gleseracid. There's some discussion about how to pronounce this. So this is a G12 inhibitor that was studied in a phase 1 dose escalation and phase 2 expansion schema in pancreas cancer and other solid tumors, and we heard about the data in pancreas cancer. So here's the waterfall plot from 31 patients with PDAC. And this is impressive, with the majority of patients seeing some cytoreduction with an impressive response rate of 42%. Deep responses were observed in about a quarter of the patients and a disease control of 94%. Responses are rapid with these agents. Median time to response, 1.5 months, so the first scan. And in this study, the median overall survival was encouraging at 10.7 months with a PFS of 5.6 months. The safety and tolerability were encouraging. Most patients experienced treatment-related adverse events, but most of these were grade 1 or 2, grade 3 or 4 seen in 26% of patients, but serious adverse events only in 6%. And the most frequent treatment-related adverse events were not particularly problematic: asthenia, anemia, and elevated bilirubin. So these are the 5 inhibitors for which we have data in PDAC. A little bit of a cross-trial comparison here, and it's important to highlight that the numbers are small, the confidence intervals are large. I don't think that we're anywhere near being able to say that we have a winner or a best-in-class just yet, but this story is to be continued. And I think most importantly, this is proof of concept that if we can effectively inhibit KRAS, we can see clinically a meaningful benefit in patients with pancreas cancer. So KRAS G12D affects less than 3% of patients. So we're going to pivot now to a pan-RAS inhibitor, which has the potential to impact more than 90% of our patients with pancreas cancer. This was a presentation at ESMO with the Revolution Medicine pan-RAS inhibitor, RMC 6236, again, a phase 1 dose escalation study. So RMC 6236 is really an interesting first-in-class pan-RAS inhibitor. It covalently binds to cyclophilin A, changes the conformation of cyclophilin A so that it binds to activated KRAS, so KRAS on, actually all RAS molecules. And it's a sticky binding. They call it a glue-like molecule or glue, and inhibits the activity of activated KRAS. So in this study of 65 patients, so a good number, these were heavily pre-treated patients with the typical KRAS mutations that we see in PDAC. And here is the waterfall plot. And again, very impressive with the majority of patients seeing some cytoreduction in their tumor in this dose escalation phase, with a partial response rate of 20% and a disease control rate of approaching 90%. Treatment is ongoing, so I don't think we have enough information about durability just yet. And again, no major safety signals with a low incidence of grade 3 and no grade 4 treatment-related adverse events, but a notable incidence of grade 1 and 2 adverse events, which might be problematic for tolerability in the real world. So this is, I think, a really exciting new drug. It's this first-in-class RAS multi-on inhibitor. Seems to be well tolerated with very encouraging anti-tumor activity in this preliminary data in a heavily pretreated patient population. And obviously, there are many studies ongoing and planned for this drug. So KRAS inhibition in pancreas cancer. This is exciting. It's been over 40 years since KRAS was discovered and its significance appreciated as an oncogenic driver. We've referred to this throughout my career as the Holy Grail, and it is now within reach. I think these studies are proof of concept, mission accomplished. When we can inhibit KRAS, we get meaningful efficacy in patients. These KRAS inhibitors in the aggregate, and there are many, have the potential to really favorably impact the majority of our patients with pancreas cancer. I think we expect the durability of response with monotherapy is going to be short. We know that emergence of resistance will be inevitable, and there are many ongoing studies trying to understand that better and how to overcome it. And I think we all expect that combinations will be necessary to enhance efficacy. And again, many studies planned and ongoing. So I'm going to turn now to another target. I thought this was a really exciting presentation. And this is targeting NRG1 fusion. So NRG1 is a ligand that binds HER2 and pushes it to dimerize with HER3 and pushes it to dimerize with HER2 and activates the HER2-HER3 heterodimer complex. NRG1 fusion proteins are oncogenic drivers in a small percentage of patients, and in about 10% of our KRAS wild-type pancreatic cancer patients harbor NRG1 fusion, so about 1% overall. So this is a presentation looking at a HER2-HER3 bispecific antibody that binds the heterodimer and prevents the NRG fusion protein from binding to the heterodimer and inactivates it. So here is, again, another stunning waterfall plot in pancreas cancer in 33 patients. So they were able to get a reasonable number for this rare driver mutation or alteration with a response rate, again, of over 40%. It looks like the responses are durable with median duration of exposure of 9.4 months. Again, a quick time to response, median time to response of 1.8 months. I think this is really exciting data, and hopefully this is an agent that will get a tumor agnostic approval by our FDA in due time. So back to our pie chart and precision medicine, a reality in pancreas cancer. So we've talked about KRAS, we've talked about some of these fusions, and there are other targets slicing into this pie. We all know about BRCA affecting about 5% of our patients, for which we already have a targeted therapy with olaparib. But up to 40% of patients have homologous recombination deficient tumors other than BRCA. And this is a target that we can exploit with drugs such as ATR inhibitors that are in clinical trial. I think a newcomer for targeted therapy is MTAP loss. About 20% of patients with pancreas cancer are MTAP null, and this is going to give us an opportunity to target other drugs to achieve synthetic lethality. An interesting approach here is targeting PRMT5 with an inhibitor that does appear to induce synthetic lethality, and we're excited to get these drugs coming into the clinic, and we will have a study with a PRMT5 inhibitor here at Yale, hopefully opening up over the next year. So take-home points from these studies, are they clinically relevant? They're not FDA approved, but yes, highly clinically relevant. Proof of concept, and I think we fully accept expect that precision medicine approaches will become the standard of care over the next decade in this difficult disease. So a story to be continued, and we're really looking forward to the ongoing chapters. Practice changing, again, these drugs are not FDA approved, so not immediately, but I say yes, because what this is telling us is that we must have all of our patients with advanced pancreatic cancer undergo next generation sequencing of their tumor. That is difficult because often we don't have enough tissue, so we have to think more about rebiopsying or doing liquid biopsies. And then we have to be familiar with the targets and make sure that we're referring patients for clinical trials with these promising targeted therapies. So here's the treatment paradigm for metastatic pancreas cancer in 2024. We're still very, very dependent on traditional cytotoxics. We've gotten mileage out of them. But again, the reminders are next generation sequencing on all patients, consider clinical trials in the first line setting with our chemo backbones and investigational agents added to the chemo backbone. And then in the second line setting, we have to be thinking about targeted therapies. The second line setting is probably the best setting to do this because as we move into the third line setting, often our patients are no longer candidates for clinical trials with declining performance status. So now I'm going to pivot to localized disease and discuss the NORPAC-1 study, and if time permits, we will talk briefly about adjuvant vaccines. So localized resectable pancreas cancer, these are our curable patients, and the current standard of care, of course, is surgery followed by 6 months of adjuvant chemotherapy with FOLFIRINOX based on PRODIGE 24, published in New England Journal of Medicine in 2018. And this was a very exciting breakthrough study with a dramatic improvement in progression-free and overall survival with FOLFIRINOX compared to gemcitabine. We now have seen the long-term follow-up from this study published in JAMA Oncology a little over a year ago. And again, the impressive difference in PFS and OS is holding up, so that's really encouraging. However, the 5-year disease-free survival is just 26%. So I think what that is telling us is that we aren't curing the majority of our patients, and minimal residual disease remains a challenge, a huge challenge actually, in localized pancreas cancer. We learned a few more things from this long-term follow-up. This is important, I think. Completion of all 12 cycles is important with a hazard ratio of 0.64 of 12 cycles versus less than 12 cycles. Interestingly, dose density is less important. So reducing doses and spacing treatment out does not seem to have an impact, but completing all 12 cycles is important. So why are we focused so heavily on neoadjuvant or preoperative FOLFIRINOX? There are many, many retrospective reviews and smaller studies looking at this, and that is because we hope that if we can introduce systemic therapy earlier in the natural history of the disease rather than waiting till after surgery, which is often a delay of months, that this could potentially make chemotherapy more effective in eradicating minimal residual disease and thereby increasing the cure rate. There may be other benefits as well, including increasing the R0 resection rate, decreasing surgical morbidity. There are also some concerns in terms of complications that could evolve as you go through neoadjuvant chemotherapy. So the NORPAC-1 study was designed to address this important question of neoadjuvant FOLFIRINOX. And here's the schema of NORPAC-1. This study was conducted by our Scandinavian colleagues. That was a multi-center randomized phase 2 study. Patients were randomized to upfront surgery followed by adjuvant FOLFIRINOX versus neoadjuvant FOLFIRINOX, full dose FOLFIRINOX for 4 cycles, and then on to surgery, and then adjuvant chemotherapy with FOLFIRINOX. Primary endpoint was overall survival in the intent to treat population. So there's some, I think, important points to raise about this study before we go through the findings that I think inform how we interpret this study. So first of all, a pathologic diagnosis was not required prior to randomization in the upfront surgery group. So patients did go into the study and had surgery who did not have pancreas cancer. They excluded patients with tumors of the body and tail, included only head only, which is interesting. Those are the patients that might run into the most complications because of biliary stents with the neoadjuvant approach. In terms of neoadjuvant FOLFIRINOX, they used full-dose FOLFIRINOX, not modified FOLFIRINOX, and they did not include prophylactic GCSF, so that gets to the tolerability issue. And then in terms of the adjuvant end of the study, adjuvant therapy was at the treating physician's discretion, which is interesting. And initially, at least in the first 21 patients, it was gemcitabine or GemCape, because this study was initiated just prior to the data coming out with adjuvant FOLFIRINOX. At that point, the study was amended to adjuvant modified FOLFIRINOX, as in the randomized trial with FOLFIRINOX. So this was presented at ASCO. This study got a lot of media attention, really, I think, with the take-home message in the media being that we should not be using neoadjuvant FOLFIRINOX. So we'll talk about that a little bit more. And this has now been published in Lancet as well. So here is the progress of patients through this study. And we see what we see in all neoadjuvant trials. There is a drop-off as you go through the study, from enrollment to starting neoadjuvant therapy to completing neoadjuvant therapy. And I think what's really notable is that less than 50% of patients completed just 4 cycles of neoadjuvant FOLFIRINOX. And if you look at other neoadjuvant FOLFIRINOX trials, this is really quite a bit lower than what we're used to seeing. In these 4 studies, for example, about 80% of patients completed 4 or 6 cycles of neoadjuvant FOLFIRINOX or modified FOLFIRINOX. And then when you look at the adjuvant part of the study, only 13 patients in the neoadjuvant arm received adjuvant FOLFIRINOX. And this is highlighting the adjuvant therapies that were administered. So the majority of patients actually did not get adjuvant FOLFIRINOX. They got adjuvant gemcitabine-based chemotherapy or even 5-FU monotherapy. And a minority in the neoadjuvant arm completed all 6 months of chemotherapy. So with all of that, this is the data. There was a numerically lower PFS and OS with neoadjuvant FOLFIRINOX, but it was not statistically different in both the intent to treat analysis and in the per protocol analysis. And I'm showing here the per protocol analysis, PFS and OS, and you can see the difference in PFS and OS, median survivals. In terms of the 18-month progression-free survival, it was quite similar, 38% in the neoadjuvant arm and 42% in the upfront surgery arm, and that was not statistically significant. We did see better histopathologic outcomes in the neoadjuvant arm with a higher rate of node-negative disease and a higher rate of R0 resections, statistically significant. So these are the author's conclusions that neoadjuvant FOLFIRINOX, and I would add, as it was conducted in this study, did not improve overall survival compared to upfront surgery, and that their results do not support neoadjuvant FOLFIRINOX as a standard of care. So we've highlighted the limitations: small study, no central radiology review, full dose FOLFIRINOX without growth factor may be a poor tolerability issue. A low percentage of patients finished protocol therapy, did not receive 6 months. So my conclusions are that the data did not support or refute neoadjuvant FOLFIRINOX, highlights the challenges of these studies, and highlights the need for a well-designed trial addressing the sequencing of modified FOLFIRINOX with surgery. And such a trial is ongoing in the United States. This is the Alliance study. This is a high priority study of perioperative FOLFIRINOX, 8 cycles before, 4 cycles after, with compared to adjuvant FOLFIRINOX with central radiology review, growth factor use, planned 12 cycles. The study is open at Yale and a high priority. Our Dutch colleagues are doing virtually the identical study as well. So I think we will get an answer to this very important question. So the take-home points are from NORPAC-1. Is it clinically relevant? Yes. Surgery followed by 6 months of FOLFIRINOX is a current standard of care and remains a standard of care. But neoadjuvant FOLFIRINOX is appropriate and indicated in selected patients, certainly those with vascular involvement, organ invasion, high CA 19-9. Is it practice changing? I would say no, not really. And it's only the well-designed randomized trials that are ongoing that are going to settle this issue. And we should think about referring all patients for the Alliance study to try to address this question. And I know I'm out of time, so I think I will pause here and leave the vaccines hope or hype story for another day. And Thank you all for your attention, and I would like to acknowledge the authors of the abstracts and posters. I used a number of their figures.
Great. Thank you, Doctors Cecchini and Lacy. Jill, do you want to put on your camera and then we'll do a little bit of Q&A. Those were both fantastic. I'm going to share screen and just mention a couple of our trials, and we'll ask our audience to be thinking about some questions. So I think we're excited because a lot of the enthusiasm that you just heard, we're starting to bring many of these new drugs into our clinic. I think that as many cancer centers and clinical trial teams experienced, we had some dip during COVID and are really excited to have a robust clinical trial portfolio. So I'm going to put these up mostly to just demonstrate to you some of the things that we have. We're not going to go through them in detail. I'll leave them up long enough you can screenshot them. And just in terms of giving you a sense that in gastroesophageal cancer, we're examining things, agents such as anti-TIGIT, anti-TGF beta 1, claudin 18.2, HIF2 alpha, anti-FGFR2b. So you can see the theme is really looking at novel targets, novel immunotherapies. Dr. Lacy will be talking probably about many of these when she gives that focus to gastroesophageal cancer talk in May. Pancreas cancer, Jill, I might, just because we have this exciting vaccine study and you didn't get a chance to talk about it, do you want to just say a couple words about why we're excited about vaccine studies?
Yes, so we heard this year about an adjuvant vaccine that's referred to as a personalized pancreatic cancer vaccine. So this is truly a personalized vaccine that is developed after surgery. So these are patients that are eligible for upfront resection. The tissue is harvested and sent to Germany to BioNTech, where the DNA and RNA is analyzed and highly immunogenic neoantigens are identified. And then mRNA vaccine is generated based on the same technology used for the COVID mRNA vaccine. The vaccine is then shipped back and administered to the patients. They also get 12 cycles of FOLFIRINOX and then continued adjuvant personalized vaccine. We've seen the initial clinical data with this approach, and it has been published. It's extremely promising. We are seeing, again, proof of concept that this vaccine does generate pancreas cancer specific immune responses and activated T cells. Those patients that have strong immune responses seem to have better progression-free survival and a lower rate of relapse. So very importantly, we are now going forward with a randomized phase 2 study with upfront surgery followed by FOLFIRINOX standard of care versus upfront surgery followed by personalized vaccine, if it can be successfully generated, adjuvant FOLFIRINOX. So this study will be open hopefully within a month here at Yale. And again, I think the initial data is promising, and we hope that this can be borne out in a randomized study.
Thanks, Jill. We also, this is our HCC portfolio currently looking at, I'd say, especially the neoadjuvant and currently on hold Morpheus studies are really examining multiple arms in the neoadjuvant setting, IO combinations, and similarly in the advanced setting. Colorectal cancer, we have lots of options, which is exciting to see this portfolio grow. Michael, do you have any comments? Want to pick out one or two that you're really excited about to mention?
Yeah, absolutely. So I think that, again, there's a lot of enthusiasm around ctDNA, but how to exactly use it, we're still figuring it out. And again, the predictive nature. So we have studies looking at that in the adjuvant setting. With the Circulate study, which is this top study listed there. But then in the metastatic setting, we have many studies that are available for our third line setting or our second line setting. So the third line setting, we have the Exelixis study with XL092 plus atezolizumab. And then in the second line setting and third line setting, we have FOLFIRI plus IGM-844, a DR5 agonist, which we've had this study in phase 1, so it's moved into phase 2, so that's very exciting. And we're bringing new studies in these treatment refractory scenarios with ABBV-400, et cetera. So, yeah, a lot going on.
Great. And lastly, I'll mention we have 4 neuroendocrine studies open. A few of these are through our national clinical trial networks, which is actually a great way to do rare disease research. And I'll highlight one. We have a novel radioligand therapy. This is the RAISE 101 or Action 1 study. This is really drawing from what we've learned with ludotatate and taking a different radioisotope that is an alpha emitter. So alpha emitters or alpha particles travel a shorter distance but have a higher energy level. So the theory is that it will be more effective but less toxic. So we've just opened this study. This is a national study, and this is for patients actually who have had already a standard course of Lutathera and have progressed 6 months or greater after that. So I will stop share. So that's just a little bit of in fact, that's probably not our entire portfolio, but it's the large bulk of it. And I'm happy to open this up to questions, but maybe I will, I'll start off by asking Michael and Jill really the same question, which is, something that's forward thinking. I always I end a lot of my patient visits this way. Like, what are you hopeful for? What do you leave your patients trying to be hopeful about? Maybe Jill, you can focus on pancreas, and Michael, you can focus on colorectal.
I'll start since we can go in the order that we presented. Well, I'm really hopeful for how we're recognizing colorectal cancer as different diseases based on certain characteristics, and so that we can really personalize treatments and for patients. I mean, we've realized that the different location of the cancer in the left side versus the right side has certain potential for certain treatments. And now we're revealing things like KRAS G12C. Dr. Lacy kind of highlighted some. I think that the G12D inhibitors or pan-KRAS inhibitors are entering the clinic. So we're understanding HER2 positivity. We use the treatments differently. And so targeted treatments where we're getting the right treatment to the right patient at the right time. I think we're really improving how people are doing with that approach, and also de-intensifying and using less toxic therapies. So that's been exciting.
Great, thank you. Jill, what do you think?
So I think for much of my career, there has been therapeutic nihilism about pancreas cancer, and I think there's no reason for that. We are improving the outcome for patients, even without major breakthroughs to date. We are seeing that survival increase quite substantially. And I think now we are on the verge really of a major leap forward with the precision medicine approach to pancreas cancer. I think it's upon us. We see that we can inhibit KRAS, again, the holy grail, and there are other targeted approaches. And I think the field, I think, is really going to open up. And, I think it's just very important that we encourage our patients, to stay optimistic. We want to get that next generation sequencing. We want to try to find trials for them. And I think that, of course, for us, even here at Yale, can be difficult because we don't have every trial here. So finding the right trial for a patient is a lot of work, but I think we all have to be committed to that. We are fortunate that we live in a part of the country where there's a lot of cancer centers with a very large portfolio in the aggregate, and try to get our patients to these trials with targeted therapies. So I think it's a really exciting time in pancreas cancer, and I'm just really looking forward to the next couple of years and see how things evolve.
Yeah, I agree, and I can kind of speak specifically to the neuroendocrine world. I think that even for cancer that does not typically, we've not thought of it as of using targeted therapies, but actually somatostatin receptors are a really great target, and we've proven that with the use of radioligand therapy. And and I'm reminded it's like such a privilege to be able to be a clinical researcher and see patients. It's really, that balance, I think, of really having hope for the future around what we're doing and the clinical trials that we're bringing. And I think, many of our patients, I hope, will benefit from that. So, I know both of you contribute to that. So thank you for talking tonight. And and for the clinical research that you do. And I'd say thank you to our patients who participate in clinical trials. I think that really helps move the field forward. And certainly we and our colleagues are happy to answer future questions from our community. This is really a CME, but I think that if there are patient questions or physician questions, I'm sure any of us would be happy to take emails in the future. I put up our phone number for our clinical trials office and a website that were on the slides. This presentation will be made available, and an archive video will be available pretty soon. And I guess I'd love to ask that please come back for our 3 subsequent lectures in our CME series, and those will be monthly for the next 3 months. So Michael and Jill, anything else to add?
Thank you all for sticking with us through the evening.
Yeah.
Yeah.
Exactly. Well, we'll
And
give
happy to take questions offline as well.
Yeah.
From anyone in the audience.
Great. Well, we'll give everyone back a few minutes to their evening. Thank you, Michael and Jill, very much. I appreciate it.
Thank you all.
Have a good night.